I think I'll start. Very good evening to all. And as Sir mentioned, that this discussion will be an complementary or supplementary to the discussion that has been done by Dr. Pratibha Perera Madam. Now, what we are going to how to differentiate is I am going to discuss how to approach, and what is to be done is already discussed by Pratibha Perera Madam. So in the last class, so how to approach a older person in your OPD, that is what we will discuss today. So I bring greetings to you from Department of Geriatrics at Sri B.M. Patil Medical College Hospital Research Center. We have 2 MD geriatric seats and 1 batch is already out. And we have a variety of activities in promoting health, preventing social, training, rural health as well. So to begin with, in next 40 minutes, let us know what are the goals and principles of clinical approach, what are the domains and how is the history taking differs from that in the adult patients, how general physical examination differs, how we should apply the care modalities for a given patient, and we should also know about the caregivers or the care partners. It's very important issues. So when we come across an older person in a clinical practice, it is basically a patient-centered practice. So what is that we will discuss now. So what should be our goal? So when an older person comes to us, we examine him and we have to identify a core problem, because they will be having multiple problems, among which is the problem that is bothering him most. Then be a part of solution. This is the era where we cannot tell the patients that nothing can be done, go home. This is the era where we can try to be a part of solution, reduce the pain, improve the quality of life. Most of the older people don't fear death. They say, just let the death come, I'll accept it. But I don't want to be disabled. I don't want to be dependent on my caregivers. That is how I want to have a good death. And definitely, as a clinician in geriatric practice, we should strive for a dignified death for every older person you come across in our clinical setting. So with these goals, I just like to brief you that any person who becomes a senior citizen today, maybe just enters the age of 61, will be living another 17 years. So a 60-year-old person coming to your clinic today will be living another 17 years and will be with you. And how to go with it, I'll tell you. Clinician must know what is and what is not part of the aging. This is what most of the physicians lack. That's why they just keep blaming that, oh, it's a part of aging, nothing can be done. No, at least we must be clear. When we approach an older person, it differs from person to person, of course. It differs at different ages. A person in young old, like 60s and 70s, and the one in 80s and 90s, your approach will definitely differ because of the problems associated with them and the impact on quality of life. And at different stages of the disease in the same person. So today you make a diagnosis of Parkinson's in a given person. Over next 5, 6, 8 years, patient will be with you. And every third year, new challenges comes. So as a clinician in a geriatric practice, you must be aware and be ready to handle these challenges. Of course, one should have passion, patience, empathy, skills, especially communication skills and observation skills. Very important. How they are behaving, how he is getting up from the chair, how he is walking, what is his gait, what is his gait speed. All these observation skills are very, very important for a clinician. And a gentle touch. It may be an emotional touch, a psychological touch, or a pat on his back. Holding his hand while sitting on the chair matters a lot in your clinical scenario. So, what are the principles? It should be a person-centered. We always strive for the functional age rather than the biological age. We always try to ensure that this person has a good functional quality till his death. Instead, whatever age for us matter doesn't matter for me. Good communication is the key. That is what the older person seek. When you start medicines, always start low and go slow. Prevent what all can be prevented. This is what I'll show you again next. Please don't prescribe pill for every ill. Some issues in the geriatrics also you need to ignore, for which you don't go on giving pill for everything. Do not have an ageistic attitude. And as William Osler once said, a wise clinician knows when not to treat. So in geriatric care, we should also be aware that which symptoms should not be treated and which symptoms should be given priority. So we classify the older people into three groups: young old, and very old. This is an international classification. In India and WHO and UNICEF, we consider 60 as older persons, whereas European countries and United States are all they consider 65. So young old, the most of the persons, 90% of the people in the age group of 60 to 74 are independent. You must have seen they're coming alone. They drive the car, they ride the cycle, bicycle, scooter, and come to your OPD, manage everything on their own. Old, 75 to 84, on 50 to 60% require assistance. And very old, those who are more than 85 years, 90% of them are dependent on their family members for day-to-day course. If he wants to come to your OPD, it depends upon his son or a daughter or a paid caregiver because they're dependent on them. And right now in India, the population of 80 plus is increasing. And all of you clinicians will be coming across these persons above 80 years in a clinical scenario. So what are the domains? When we come across an old person, what are the domains we should deal with? They are physical, mental, social, what care modalities we can provide to them, know the caregiver, what all we should prevent in them, what are the spiritual aspects and emotional aspects and economical aspects you have to come across. So physical means what are the diseases they are having, the complications of the disease, and the disabilities that has produced. So when you compare to adult medicine, geriatric medicine deals with all those three. For example, diabetes, diabetic retinopathy, and the blindness that it produces. We have to deal the person with not only disease, its complications, and the disabilities that is produced. Mental health, depression, loneliness, anxiety, suicide. I agree. I hope you all of you agree that now there is loneliness is much more common in the older persons across India. Social issues like elder abuse, ageistic attitude starts in the home, apart from the community, being isolated or staying alone. You have to address these issues in the social domains. We all must know the indications for palliative care, rehabilitation, hospice care, day care for various diseases the person will be having. So this is what I was telling you, that there is a solution. Be a part of solution. Okay. Try to know the caregiver. It is very, very important. If you want your treatment to be successful, always know the caregiver and ask them, how are you doing? And are you having any problem? So they will be maybe burnout. Sometimes they feel helpless. They come and cry in our clinic. Sometimes they are providing long-term care for an older person for 5 years, 10 years on the bedridden. They are not trained. As a clinician, we must prevent a fall, vaccine preventable diseases, polypharmacy, that is irrational polypharmacy, should be avoided at any given cost. When a patient is admitted under your care in your hospital, ensure there is no bed sore. Ensure there is no bed sore. And don't be very aggressive in treating diabetes or maintaining the sugar levels, causing hypoglycemia. That further leads to falls and further leads to fractures. So all this has to be prevented in your clinical approach. And I was telling you, apart from economical aspects, end of life care issues should be discussed. And in the person whom has end of life diseases or terminal illness, always think of discussing advanced directives. It's very, very important. So when an old person comes to you today in your clinic, you may be dealing in a person with variety of these issues. You may have a patient today with a victim of elder abuse. You may come across a patient with CA colon who requires palliative care, or a stroke, he needs a rehabilitation, and a caregiver coming and crying in front of you. And you will come across a person who will ask you, sir, which vaccine I should take? I just read an article about that you have written. So at any given time in our OPD, you need to address all these issues in one or the other patients and multiple issues in the same patient. And don't hesitate to initiate advanced directives for your older persons. Just ask them, have you written your will or not? That will inform them that my days are numbered and they should go for and write for an advanced directives or a will. Ultimately, when you examine all these domains, the main crux of our goal is maintain the function of the older person. Now, these are the symptoms that misguides us for a clinician in older population. Osteoarthritis of knee joints, patient will have limited and very slow mobility. So the symptoms suggesting of heart failure or exertional dyspnea as a part of heart failure will come late. Patient doesn't experience this unless there is a severe heart failure or rejection fraction. Beta blockers, yes, they are good. They are good for older persons. They produce bradycardia. Now, if the patient has hypoglycemia, they will not develop tachycardia. If patient has GI bleed somewhere, they will not develop tachycardia. So that sometimes masks. So you should be very careful. Cognitive impairment. Sometimes older person comes and they don't recall, or they tell some symptoms and go back. And next time when the relatives come, they tell, sir, he is having some mental issues. He forgets where to go. Has he told you that he has cough for last 1 month? So this is how the cognitive impairment sometimes is missed. And older persons never present with classical symptom of fever. In older persons, it is either increased thirst or reduced appetite or giddiness. That can be a presenting feature of fever because thermal regulation is impaired. So you don't expect the older person to complain fever. If he is telling that my appetite is reduced for last 4 days, think some infection process is happening in them. So I was talking to you about patient-centered approach. So in adults, when we deal with adults, it's a differential diagnosis, then arrive at a single diagnosis, treat and send him over. But in older persons, presenting symptoms often have more than one cause and involve more than one organ. Not only that, we should also know what are the social concerns, what are the emotional concerns, psychological concerns of the given patient. A holistic management is more important in the older persons. So when you talk to the person history-wise, you should always ask two questions. The symptom that disturbs you most and the activities you have stopped recently. As you know that the activities that we do out of our home, they're considered as instrumental activity of daily living. And that is the one which is affected first in the older person. So if the person comes and tells you that every day I used to go for early morning walk and I have stopped for last 10 days, then definitely there is some serious illness that is happening in him. Some signs like missed beats, one ectopic somewhere in the 1 minute, absent deep tendon reflexes at ankle, loss of vibratory sensation, diminished arm swing, delayed verbal response in most of the older persons are common in elderly, and they are not considered as a disease as a part of it. They are considered as part of aging. While you take history, always take the history from surgery in the past. Have they received any vaccines? Is he a victim of abuse? And they will not reply in the presence of their family members. When they come alone, they will talk to you, discuss about their mental health, and know who is the caregiver. It's very important. Two questions related to constipation and falls are mandatory for all patients because they hesitate to talk about this. So ask, did you had a fall in last 6 months or 1 year? Do you have constipation? See, this will improve their quality of life. Now coming to geriatric giants. So immobility, falls, incontinence, pressure sores, confusion, all are called geriatric giants because they can be a presenting feature of major illness in the body. For example, falls can be a presenting feature of acute myocardial infarction. Now, this is being, super by Mary. He brought in the new concept of the same things and 5Ms. So the 5Ms are multi-complexity. That person has live with multiple chronic conditions, advanced illness, and with complicated biosurgical needs. This is what I meant with a same person at different ages or stages of his diseases. Then another M stands for mind. So you should look for mentation, dementia, delirium, mobility, medications. Dr. Ashish will talk about all in detail about medications, polypharmacy. And this is what is very important now. We have been talking for last 10 years to ask what matters most to you. That is what you should the first ask. What is that matters to you most? What is that is disturbed in you? That is where we should hit rather than enforcing what all we know to them. This is a lady who came to us with a history of fall. First time coming to the hospital in her lifetime. She had a fall and had ecchymosis on the left upper eyelid. Luckily, she didn't have any neurological symptoms. On examination, her blood pressure was 200 by 120. Random blood sugar was 220 milligram per deciliter. Now, what we should do? Of course, can anybody put in the chat box? What next you want to do?
I think first stabilize her blood pressure because it is too high.
Okay.
And then once that is settled, a clinical examination on her to understand why she had a fall.
Fine. So that is good.
Endoscopy.
Yes. And the first answer that
Maybe
can
she
have a
may
CT, I
have
guess.
problem with the vision.
So do a CT scan. Okay. So this is what we should
Yeah.
do for her. Okay. CT scan for this patient. Right. So what will happen if the CT scan we did this lady? She had a huge infarct in the parietal occipital area. And why this case I am telling you is the lessons learned from this patient are atypical presentations, stroke presenting with the fall. Of course, that we don't classify as a fall, but she had presented us. Undiagnosed non-communicable diseases. They presents with complications. She is having hypertension, diabetes. It has led to stroke. That's how she has presented to us. Luckily, she didn't had any disabilities like hemiplegia. That's a good thing that happened with her, but not with all patients it happens. This old man had come to us with pain in the neck for 3 days onset for it was exaggerated, and he took azithromycin, paracetamol, no relief. So we in a geriatric practice, we asked direct questions with them. Is this pain comes on exertion? He said yes. And as I told you, what activities you stopped recently? He said dropping the grandchildren to the bus stop early morning was my first duty every day I do, and that is I have stopped now. Now, how many days since you stopped? It was 15 days. So which activity has stopped now in this patient?
Walking.
And
Locomotion.
okay, look, instrumental activity of daily living has been stopped. Okay. Now we made a diagnosis of angina. We got evaluated. This is very classical pain in the neck on exertion. Coronary angiography revealed triple vessel disease, and he underwent coronary artery bypass graft. And he returned back to follow up with us. Very happily, he came and said, "No more pain in the neck." Now I just asked, "What are you doing now?" He said, "I'm going back to drop my grandchildren to the bus stop." So atypical presentations sometimes or angina, you should try to understand in these patients. They will not come with classical chest pain. As I was mentioning you, instrumental activity is affected first, then activity of daily living. And all interventions has to be done to improve quality of life. And as one of the participants asking, what is ageism? So ageistic attitude. Now you are 75 years old. Why you want to go for open heart surgery? That is ageistic attitude. But the family members are very kind. They got him operated and he is all right, back to work now. This lady is just 60 years old, came to us with known case of diabetes, hypertension, chronic kidney injury, anemia, and right eye cataract. Now she presented to us with right-sided cellulitis, diabetic foot. Now, despite treatment for 3 days, now she started complaining breathlessness. So ECG was not very classical, suggestive of any ischemic heart disease, but still we went for echocardiography. Echocardiography showed evidence of ischemic heart disease with ejection fraction of 45. And this is, so what are lessons learned in this patient? Multiple comorbidity, its complications, acute disease exacerbates existing diseases, new disease get added. Every time they come to your hospital, they get admitted, a new disease is diagnosed and gets added to the list. And of course, she is now for the imminent disability for having low ejection fraction over a period of time. Communication plays a very, very important role. Always get a patient attention and always face the person while talking. Don't use distractors, mobile phone when you are talking to the patient. They will outrightly scold you. Use gestures, and your body language matters most. They can judge you on your body language. Speak clearly. Do not shout. Never wear mask while talking to the older persons, because that reduce the amplification of your speech. And also they are very good in lip reading, so you're obstructing your lip reading. So that is how the patient, you have to communicate with them, and always try to know who was it before and what is now, because this persons from class A officers, they expect a lot of things to happen, but nobody is listening to them in the home. They seek privacy, means they want to discuss some issues regarding sexual health, elder abuse, and if you had asked some history of fall in the presence of family members, they may not tell that time, but when they come alone next time, they will try to tell you that, Dr. Sir, this is what happened to me. So communication in the patient who has tracheostomy, he cannot speak, okay, voice is not coming. So we tell them to write what is your problem. And some persons keep coming and telling you, sir, I forget, I don't know what should I tell next time when I come. So we tell them to write what are your problems, or tell your grandson to write what are your problems. So they make the big list of problems what they had in last 2 or 3 days, and they bring and give this to us. So that is how we communicate with the people who either have forgetfulness or those who cannot speak or tracheostomy. This is the experience of all clinicians here. I agree. I hope you agree with me. Multiple files. Yes. Geriatric care this is what happens. Multiple consultations, multiple specialists, and then they come to you. And once they feel that you are the better person, then they stick to you. Then no more files will added. We'll be discussing in the next class about this polypharmacy. There's a concept called brown bag. What we do in our geriatric practices, we tell them to bring all the medicines they're taking, including eye drops, ointments, everything. And we sit and remove the irrational drugs. And this lady wanted only 5 drugs to be taken. Unnecessarily, she was dumping so many medicines in her body. So irrational polypharmacy leads to drug-drug interactions, leads to fall, prescribing cascade, and affects nutrition status also. So this is where we should be very careful in geriatric care. Now, when we examine the vital signs, apart from all the patients, you should record standing and sitting blood pressure. Those are antihypertensive to detect orthostatic hypertension. Always ask for the pain, look for delirium, and record weight every visit. So that will tell you whether there is a weight loss, which is voluntary or involuntary weight loss. That will tell you to make another diagnosis. In general physical examination, always look for the aids that they are using, hearing aid, dentures, all those things. Bruises from falls or abuse. Most of the time, older persons, they are very smart. They use full shirts and they don't want to, they hide their bruises and all. And you have to check those things and ask them, why is this? Always look for the bed sores. Any patient is brought to your hospital for admission, turn the patient back and look for bed sores and take a photograph and show to their children. See, the bed sore is already there. It's not in my hospital, it's in your home. Because they'll create the problems when then you tell of second day or third day, Dr. Sahib, it happened in your hospital. You should be very careful for this. Look for dehydration, ankle swelling, joint deformities, and oral cavity. So this is all apart from the regular general physical examination you do in all patients. This is what you should look for additionally. The get up go test, which has been described by madam, so I'm not going to discuss. 3-item recall test. So we talk or show to them and we'll ask them after 10 minutes. If they don't answer more than 2, then we have to submit him for further cognition evaluation. So you all know that for nutritional status, you have to use mini nutrition assessment, which has been discussed. Cognitive status, we use MOCA in our college, and our PGs are also trained by MOCA certificate. Psychological status, geriatric depression scale, polypharmacy, a brown bag concept, functional capacity, activity of daily living, and instrumental F, which has been all discussed. So vision, hearing, spirituality, sexual history is very, very important. Frailty by a frail scale, sarcopenia by measuring calf circumference, all has been discussed in detail by Dr. P. Shankar sir in his first class. So this lady had come to us with a fungating ulcer on cheek of 1 month duration. If you can see this, a huge growth. And what were the issues? The issues were intake of food has stopped because whatever she used to eat, it used to come from this hole outside. There are a lot of maggots, secondary infection, bad smell, and if you touch it, it bleeds. Poor economical status, and of course, we have to think of a dignified death. So what are the lessons learned for this case is, as after examination and all, what is our role? We have to provide a palliative care, initiate the end of life care discussion, advance directives, improving the quality of life. So pain has to be reduced, maggots has to be reduced, the smell has to be reduced. So which all we do, that itself adds to improved quality of life. And even if she is able to swallow some liquids and or some semi-solid materials and correction of anemia, that of course ends up with dignified death for her, this patient. So in patient with hemiplegia, we have as our role is to prevent bed sores and aspiration pneumonia. This is very, very important in all the patients I've been telling you. Address to dysphagia, antidepressants, rehabilitation is very, very important. So these are the modalities of care I was telling you: palliative care and rehabilitation. So rehabilitation is a process of care restoring maintaining a person's ability to live as independently as possible. So we not only examine the patient, treat the patient, but also train the caregivers or family members that there has to be some rehabilitation measures has to be applied in the home, especially these toilets, like putting the bar, putting the chair, increasing the height of the toilet. So many things has to be done for a patient with stroke, living with a stroke. Coming with mental health, I was talking to about depression was earlier, 5 years back, depression was the topmost common mental disease in the older person that we used to see. Now it has been overtaken by loneliness. Fear of losing friends is very, very common in older persons, especially those who are 80s. They said, none of my friends circle are surviving. I am the alone, and that is the punishment that I'm having. Anxiety, suicidal thoughts. Anxiety, even if they have some headache, they think that I'm going to die. He feels a little jitty or giddy. Am I going to die? That's what they go on feeling. And because of being victim of abuse, and this is a classical scenario showing the empty nest syndrome the older people that are facing across the world now. Most of them think of suicidal ideas, and many of them come and tell you, Dr. Saab, I am feeling suicidal. These are the red flag signs. Immediately you should put him on antidepressant, consult a psychiatrist, put him on counseling, call him every alternate day to your OPD till he comes out of these ideas. That is where our role is, to prevent a suicide in the older person. Older persons are victims of elder abuse. This is happening in very rich class of people, not in the slum area of this. And what is important is the impact of abuse is so much that the persons or victims of abuse are at 3 times more risk for death than those who are not abused. On August 1st, I'll be discussing in detail again regarding the elder abuse. Care partner, yes, we all are care partners by default. All the 91 persons in this meeting today, we all are caregivers by default. We have to care for our grandparents, now parents, and so when the older persons are accompanied by the caregivers, please don't scold them for any reason. They are all in the sandwich generation. They have to provide care for 3 generations in the home. Also try to know the history from them, because most of these diseases like dementia, Alzheimer's, or behavioral disorders, psychiatric disorders are all diagnosed from the history by the caregivers rather than by the patient. And please make it a habit of asking to all the caregivers, how are you doing today? Are you having any problem? Because this will boost their, somebody is listening to me, somebody is bothering about me. My husband doesn't ask me how am I, but this doctor asks me how I'm doing. And that makes them to go ahead with providing care. So ask them what is the problem and you can give us some solutions. Caregiver burnout is a state of physical, emotional, and mental exhaustion. And these, before they go for burnout, we should advise them for go for a respite care. And respite care can be done in family itself by various family members, or even if a family has 4 or 5 daughters, each daughter can come for 2 days a month and relieve the daughter-in-law for 2 days a month from this work every day. She will be having a very good backup of psychological issues back. Again, you can avoid a burnout. A lot of things we discuss with the persons here to providing respite care for the caregivers. So this is a beautiful photograph that I've taken from one of the presentation psychology students. So stroller or wheelchair, your parents and your children are your responsibility. Ageism, as was asked here, when the physician denies treatment or a surgical intervention merely based on age, this constitutes ageism. Ageistic attitude even starts with the children. Array, you are 80 years old. Why you want to get operated? We have seen 100-year-old ladies getting knee replacements. What's wrong in that? So ageistic attitude, just denying. So when we should take a call, it is a geriatric medicine physician or a physician who knows that his functional quality is still good. After even going for surgery, he is likely to lead a good life. He must undergo the treatment that is recommended. Now, this is one example I'll give you. We had a 90 years old male patient. He is my patient since his age of 75. And he is very active, still goes to his farm and does day-to-day course. Came with a history of breathlessness for 4 days duration. There's no history of fever, wheeze and expectoration. He was known case of hypertension, regular follow-up on amlodipine. His blood pressure was 100/60, non-diabetic, no other comorbidities except for amlodipine, not even cataract surgery he underwent. On examination, when we did a ECG, so ECG was showing, anybody can tell me what was the ECG showing? What the ECG reads like?
QT super low.
Yes, you can type also. Anybody else?
Block.
Heart block.
Yes,
Bradycardia is there?
yes, very
Yeah,
good.
bradycardia.
Complete heart block. This is a case of complete
First
ECG of.
degree heart block.
No, it's more than that.
AV
It's complete heart
dissociation,
block.
sir. AV
Okay, it's
dissociation.
complete heart block.
Complete heart
So
block. Yes.
we advised him to go for a permanent pacemaker. 2 children's very good position. Initially they refused. Then we counseled them. See, this is an old man who is very active. Why don't you go and what? Sir, again 2 lakhs. I have to pay 2 lakhs. How can I manage this? How is the guarantee that after pacemaker he will be moving around? They say, let us take a chance. Nothing wrong because he's so active. We can do that. Then after 6 hours, they came to me and said, sir, refer him to cardiologist, we'll get a pacemaker. So we went out to our cardiology department, discussed with the case, and this patient underwent permanent pacemaker, and the post-permanent pacemaker ECG is a very classical of back. The rhythm has come back. You can see the pacemaker waves. And after 1 week, he came to follow up for my clinic. And this is how his state is. Whenever he comes, he used to just sit like this and talk to me. So again, he's back to the work. So if we had not done the ageistic attitudes was there in their home, counseling, it takes a lot of efforts, takes time, but at the end of the day, this is the most pleasurable thing that we see, and that's the emotional attachment that comes. Now, as a physician, it is our equal responsibility that knowing the person, what all comorbidities is having, what all complications is having, what this is having. It is our duty to decide whether my patient should have death like this or a death like this. So it is again, of course, now the Honorable Supreme Court has brought living will, and in that case, most of the issues has been solved, whether to put on ICU, whether to put on ventilator or not. Okay, whether I should. Most of the patients now coming to us in our geriatric medicine are they coming and telling that first the son comes and tells, "Sir, I don't want my mother to die the way my father died in ICU. If you are going to manage her in special room or in a semi-special room, we will admit here or else we'll go elsewhere. I don't want ICU." So the most of the patients in terminal illness with heart failure, with stroke and end of life care, we treat them in a special room, surrounded by family members, allowed to meet all the family members, provide the care that they want, allow the patient to eat what they want. And in my practice, when I ask the older person, most of the time the answer is, I ask them, what is that you want to eat today, or that is the want liking of. The commonest answer was ice cream. So the most older patients tell, I want to eat ice cream. So, and we tell the children to get an ice cream to him. And they're so happy that that's what we want. Till his end of life, he should be happy. He should have a dignified death, spending time with their family members in a good environment instead of this beeping sound, tubes in the mouth, in the nose, in the anal canal, in the so many tubes everywhere. So that is how the thing. So it is we in geriatric practice should start discussing the end of life care and a dignified death to the person when they are in the pre-terminal stage. What is emerging now? Living will. We have been discussing since the last 10 years. Now, Honorable Supreme Court has given guidelines, 17 guidelines for forming a living will. And what in case if there is a difference of opinion between two physicians, you can, what should be done. Everything is mentioned in this living will. You can go. And this is a movie, a signature, which has touched the issue of not writing a will before death and how the family suffers. And nowadays, the passion for living funeral has started. Most of the movies are showing this. Before the older person dies in his terminal illness, bedridden, he calls all his family members and they discuss. They tell them, "You tell me what is that you want to talk to me after death. Don't, whatever you wanted to say to me after my death, you speak now. And I forgive you all. You forgive me." All these things are discussed in living funeral, and euthanasia is being discussed now. Another 4 countries have come into line. Earlier there was only 7 countries in the world which has legalized euthanasia. Recently even UK brought this law of euthanasia. 11 countries across the world are now legalized euthanasia. So people will ask you, how is this? Can we go for this? So all these things geriatrician practice must know. So the take-home message: aging is not a disease, although diseases are most definitely among the most common and detrimental consequences of aging. Aging is physiological. Clinical approach is full of challenges, and you have to struggle. And sometimes you may have to say the patient to come back tomorrow again because my mind is not working after some time. Every second or third person in the clinic is short of hearing. You will be putting a lot of energy. Of course, not shouting, but convincing him. Ensure that he understood what you are telling. Ensure that you have understood what he wants to tell. And put the medicine list in order and send him. This takes a lot of time and efforts and your energy. Definitely, the geriatric care differs from that of middle-aged care. I hope you agree after knowing this course. The main goal should be to maintain adequate function in the older persons despite comorbidities and disabilities, should be our priority. Please be a part of solution. Never say nothing can be done, go home. No, we can do a lot of things for their improving. They know it. The old man with severe rectum, with secondaries in the liver, he knows that my days are numbered. What is he expecting? The pain should be reduced. At least I should be able to eat. At least I should have good night's sleep. Okay, give him sleeping pills. Nothing wrong. Reduce the pain. A lot of modalities are there available to reduce the pain. That is what we have to think and provide to the older person. So always talk to the person. What is that bothering you most? And what activities you stop? That is, in a nutshell, what matters the most. We have to address that rather than enforcing what we know or what we think of. And I'm again repeating, as a physician, please don't have an ageistic attitude. Try all the best, what best we can do. And we have seen many legends having open heart surgery twice, thrice, and they have lived up to 90 years. So that is how we can make their life a good quality life. So thank you, my dear friends. Just to end, I quote James Sterling Ross: "You do not heal old age, you promote it, you protect it, and you extend it." Thank you so much. And if you have got any critics and all, let me know. So because I'll improve next time. Thank you so much for your patience hearing. Thank you.